Good evening, everyone. My name is Gilbert Saenz. I'm with Dermcast TV. Tonight, I have the pleasure of speaking with Dr. Adam Friedman. Dr. Friedman is professor and chair in dermatology at George Washington University, GW. Tonight, we're going to be speaking about hyperhidrosis. Dr. Friedman, thank you for joining us. I really appreciate your time, and I know it's kind of late here in the evening, and I know you've had a long day, so I appreciate you giving us some time tonight.
My pleasure, Gilbert. Make me sweat with these questions, man.
Yeah, I'm gonna try. Yes, sir.
Hit me hard. Come on.
Yes, sir. But first of all, thank you for that amazing lecture that you gave at SDPA in Los Angeles. It was really informative. I really learned a lot. I personally have been in practice almost 20 years. 15 of those, 16 of those have been in dermatology. But I feel like you always learn new things when you attend these conferences. And even though hyperhidrosis is something that I've been exposed to with my patients throughout my entire career, you always pick up little pearls here and there. So I really appreciate you sharing some of your knowledge and wisdom with that.
My pleasure.
Yes, sir. So for some of those individuals who may be new to dermatology, some of my colleagues that may be new to dermatology, could you maybe explain a little bit about hyperhidrosis? I understand that there's a few different variations, primary versus secondary, generalized versus localized. Could you maybe give us a little bit of background on it?
Yeah, I think starting off million mile high view, this is an exceedingly common problem. We're talking about a medical condition, and I want to harp on the fact that it is a medical condition, and just you telling your patient that will go so far because they've always thought that their excessive sweating was something weird just to them. That this is a condition that has an ICD-10 code, mind you, you can actually bill for it. But it's one of those conditions that is so difficult to really appreciate because it's very hard to understand where you draw the line between normal physiology and pathophysiology when it comes to excessive sweating, right? We all have to sweat. It is our internal air conditioning, so to speak. But sweating becomes pathologic when it's in excess of what is needed to stay cool. And the kind of line we draw in the sand is about fourfold what's needed to thermoregulate, to cool one's body. It is also excessive sweating that has no rhyme or reason. And what I mean by this is it could be a complete flop sweat, so to speak, sitting around in an air-conditioned room. There is no value to it. There is no biological basis to it. And so that's where something that's physiologic turns into pathology. But because it's more of a concentration issue rather than something that's visible that clearly is abnormal, I think there's an added level of burden on the sufferer in that they don't realize it's a medical issue. But also from our side, where we can really make a big difference is acknowledging it as pathology rather than just dismissing it when patients come in asking about it, which many of them, if you even ask, have really been dismissed in the past and told it's nothing. And so they end up suffering in silence. Now, we do know a lot about hyperhidrosis, and as you mentioned, there are several flavors of it. The probably most important one to know about is primary idiopathic hyperhidrosis. Idiopathic, I like telling patients, it's a fancy way of saying we have no idea. We are idiots in that respect. We don't know why this happens. We know it does. We know it's real. We may know some part of the pathophysiology, but it's happening for no rhyme or reason or one that we've been able to identify. And it's important to delineate from secondary hyperhidrosis, which you brought up, because while yes, both are excessive sweating, they are very different and certain things can be missed if you don't distinguish. So let's start with primary. So primary is a form of excessive sweating. Remember we said 4 times the necessary amount to thermoregulate. That has been going on for at least 6 months, if not longer, is symmetric, is impacting quality of life. One of the key things is that it stops when you're sleeping. That doesn't mean that you are anhydrotic at nighttime in bed. That would be a bad thing. You still will sweat. If you are under heavy covers in a 95-degree room, yeah, you're going to sweat. I'm saying that hyperhidrosis, that will decrease, or it will go to more baseline sweating, physiologic sweating, during the nighttime. Family history can also be there. Not like something you talk about, think about Thanksgiving coming up at the Thanksgiving dinner table, but there should be family history as well. So chronicity, symmetry, stopping at nighttime when one's sleeping, those are key clues that kind of, that kind of stand out to really distinguish primary from secondary, which means, as the name infers, that excessive sweating is from something else. And usually it comes out of nowhere. So it'll start in, middle of one's life. It's usually generalized. It doesn't care if it's night or day, it persists. And this type is usually associated with some underlying medical problem. This can range from, endocrinological problems. It can range from, even more concerning things like hematologic malignancy, infection, medications, you name it. So there's a lengthy list of things that can cause it. And so that's why if your line of questioning, which by the way is very important when you're talking to this patient for the first time, is pushing you in the direction of something secondary, generalized, night or day, you're sweating and it came out of nowhere, that's where a really thorough review of systems to start to get to the bottom of what's driving this. Plus, and depending on what you find out, this may even require some laboratory examinations or even some imaging, depending on what you really get out of your really thorough questioning, which is very important here. I think to round it out, is the kind of focal hyperhidrosis that can be associated with some nerve injury. Frey syndrome is a good example, or gustatory hyperhidrosis, where some nerve injury can cause excessive sweating in one location. Associated maybe with food intake or things like that. And that's a little rarer. That's not typically what we think about in general when we're trying to distinguish and manage these patients. And of course, either A, do a proper workup, or B, just jump right in and get to kind of first and second line therapies. But the main thing is primary versus secondary, and from there, what do you do?
Right. All I was going to say was I think it goes without saying that a proper history and review of systems is imperative when you're seeing these patients.
Yeah, absolutely. And I think it's also important to note, you really want to get to the bottom of how disabling this is. I think documenting impact on quality of life, first off, it shows the patient you care. These patients have, as I mentioned, the term suffering in silence is used all the time when describing hyperhidrosis patients, and they feel ostracized. And if you can show even a glimmer that you understand what they're going through, you've made a patient for life. I mean, I've had patients break into tears when I start explaining what it is, what it isn't. It's not their fault. So that's step one. But I think also it's really important to document these things, because when you try to get certain medications or treatments approved, document that quality of life can make your job easier when you're getting that prior authorization.
Yeah, you can have a huge impact on somebody's life, right?
Absolutely.
So speaking about treatments and different options, what kind of treatment algorithm, I guess you would say, do you kind of follow when it comes to these types of patients?
Yeah, I mean, it really depends on areas involved. Is it, local or multifocal disease? And I will give a shout out to the International Hyperhidrosis Society, sweathelp.org. They have published guidelines based on location in terms of delineating first, second, third line approaches, which, getting back to the whole access issue, which I think is a challenge we deal with every single day. It's like a game of Frogger, though I feel like we get hit by the bus almost every 5 minutes by insurance companies, especially when it comes to hyperhidrosis treatments. So, sharing, the reason I bring this up is sending along those algorithms from the IHHS to insurance companies can actually help get things approved. But, let's start simple. Let's start with primary idiopathic axillary hyperhidrosis. Okay, probably the most common form of primary hyperhidrosis. First line is actually a tiebreaker between the kind of clinical strength or RX aluminum salts. My advice when it comes to recommending these and giving guidance is you want to aim for the non-aluminum chloride forms, because the problem is with aluminum chloride, when you apply it and you're sweating, the aluminum kicks off, it gets into those little openings and forms a plug to block the sweat, which is great. That's what we want to do. That chloride anion will mix with the hydrogen from water and sweat, forming hydrochloric acid. And that's why, some of the higher concentration of chloride formulations are so irritating. You also want to do this at night, because your greatest chance of success is when that sweating goes down versus, during the day, you may apply it, it'll sweat right out. It never even gets into those openings. I think it's important to note that the lume zirconiums, a lot of those are the over-the-counter forms, and they usually have the term clinical strength. But also it's important to document failure, because if you're going up to the next level, for example, on a botulinum toxin injections, more often than not, insurance companies will want someone to fail and have documented failure of those over-the-counter or prescription options. So I think that's still going to be first line, but I'll tell you, most patients have already come in using those. The other thing that's first line is Glycopronium Tosylate, which is an anticholinergic wipe, the first FDA-approved topical anticholinergic for hyperhidrosis, specifically for axillary. Really nice efficacy and safety data. You do have to use it every day according to label. There are some fun off-label uses that I did discuss in my talk in terms of palmar plantar. I'll just kind of reiterate, especially for palmar, because that's a little trickier. And once again, this is off-label. You take that wipe, and this is going to be the last thing that person does, towards the end of the night. You're going to rub it until it dries, and realize it is an alcohol base, so it can be a little irritating. Put some nice thick viscous ointment, Vaseline, Aquaphor, not playing favorites. Glove up for an hour. So maybe like an hour before bed, you're going to do this. Take them off, wash off. In that amount of time, you give it an hour, whatever's going to get through the thick stratum corneum of the palms, it's going to be through. And I've had some success with that as well. But certainly for primary axillary, Glycopronium Tosylate is considered first line along with those aluminum salts, according to the IHHS. And then from there, you start to think about things like onabotulinum toxin, the microwave technology with mirror dry, and I really do not recommend surgical approaches. Radical, thoracic synthectomies. That I'm not a huge fan of those. But yeah, I think beyond mirror dry and onabotulinum toxins, between all of those, if you can mix and match, I feel like you probably can get these patients under control.
So speaking about the onabotulinum toxin, in your talk, you mentioned it as being one of the treatment options that is, I guess, most well tolerated by patients, or they feel like they get the best results or outcomes from it. How would you say you usually dose that for your patients?
Yeah, so it's different in different locations, and granted, the FDA indication is for axillary. I use it pretty much everywhere, and certainly the dosing will vary. So starting with axillary, and you bring up an interesting point about best tolerated, and I think that perception is due to kind of the longevity of it. So yeah, no one likes getting injections. Let's be real.
Right.
There are a lot of easy ways to limit the pain of said injections, whether it be with topical anesthetics, which you want to let sit for roughly 30 minutes. I actually employ the ice technique, which is a great video on sweathelp.org, where you take these rectangular pieces of ice and you apply pressure for a couple seconds, watch the skin blanch, and then you inject. Granted, I'm not lefty, I'm righty, so it'd be the other way around. You inject right next to the ice, and I kid you not, patients don't feel a thing. And that's not just for axillary, palmar plantar, where topical anesthetics will not touch that. Nothing's getting through that stratum corneum. The ice technique really makes a big difference. For axillary, I typically will do 50 units per axilla. That's usually plenty. Some patients just need more. Technically, it should last for about 6 to 8 months. Some patients need it more frequently. I really haven't seen a lot of insurances push back. A lot of my patients are getting every 3 to 4 months, to be honest. But listen, I have some insurances that no matter what I document, they want me to do buy and bill, and they'll get me on the other end. Sure, they will. Yeah, right. I'm paying for that. That's coming out of my back pocket.
Right.
Versus prescribing, and the patient goes through pharmacy benefit and has it sent to my office. So I think that from a long-term chronic management perspective, patients like it because they're not applying something every day.
Right.
Pills, I think, are a little more manageable, but yeah, the application of things every day, that can get burdensome. So patients do opt for onabotulinum toxin for that reason. Now, for other areas like palms and soles, I usually do 100 units per hand or per foot.
Interesting.
I do groin also. I do, inguinal folds, suprapubic area, and that for that whole area, we're talking about 200 units. Inframammary also, I do usually somewhere between 50 to 75 units per, inframammary area per side.
Mm-hmm.
So a little, maybe about 100, 150 units for an entire chest as well. And then also scalp is usually about 200 as well.
I was going to ask about scalp because that's an area that I feel like some patients really struggle with, but there really aren't a lot of great things out there unless you're doing something systemic.
Yeah. Oh, yeah. And I agree. I have a whole bunch of patients that I'll do injections. I mean, it's not that hard to do. I'm sure there's some, initial fear that, oh my God, if I put too much in, I'll drop the brow. you're staying pretty high. I mean, yes, this does take some skill. I've seen people do micro doses where you do higher concentration per aliquot. You do little tiny doses throughout the forehead to knock out sweat without knocking out the musculature, but that's a little tricky. But for scalp, if you stay back, you can load that scalp up. You are not going to knock out the frontalis muscle because you're really hitting it behind it.
Right.
But I'm glad you brought up systemics, which I think have a very big role, especially in multifocal disease, which I think is important to consider. Do you use systemics in your practice?
I do, yes, sir. For the most part, it typically revolves around glycopyrrolate, but I know in your talk you also mentioned oxybutynin as one of your other oral systemic medications. I think you also mentioned clonidine as one, and beta
Mhm.
blockers, which I thought was really interesting. I didn't know about that one.
Yeah, I'll be honest. I talk about oxybutynin in every talk because I like to be inclusive. I rarely use it, and that's because I think there's a greater side effect profile. Like you, I leaned on glycopyrrolate a ton, and I think how you use it and how you educate patients about it is a make or break. So I like giving patients a sliding scale. I like to give them the power to go up and down depending on how they're doing, with the understanding that this is not a spot treatment. It's not like, oh, I'm going out tonight and I want to wear a light blue shirt. I'm going to pop 2 milligrams of glycopyrrolate and I'm going to be A-OK. It does not work that way. You need to take consistently and be on it for some time before it has an effect. So what I'll tell patients is I'll say, all right, we're going to start low and we're going to work our way up. I usually prescribe 2 milligram size pills to get some extra savings in there, have them break it in half, and they'll do a half in the morning, half in the night. So 1 and 1. They're
Okay.
going to do that for a week or two. How are they doing in terms of efficacy and tolerability? We talk about dry eyes, dry mouth, urinary retention, which are really the big ones. If they're doing okay, seeing a little improvement, need more, they will go up by a half pill on either side, usually dose increments every week. I try to max out about 6 milligrams total for the day. I've gone higher, I've gone to 8 or 9, but usually beyond 6, people are not going to tolerate, especially the xerostomia, the dry mouth is really what does a lot of patients in. But yeah, I'm like you. I lean on that a lot. Now, as opposed to what I said about spot treatment, beta blockers are kind of your spot treatment. I find that more useful for I get on stage or I'm in front of a group in a meeting and all of a sudden I sweat through my armpits, or, I get the ass sweat or the flop sweat, whatever, pick your location.
Sure.
That's where I think beta blockers are helpful. So I like propanolol. I use usually with 10 milligrams. Of course, you don't want to use this in someone who has bradycardia or asthma. Those are really two big ones. And maybe even consider psoriasis, because beta blockers will worsen psoriasis. So those are kind of the three big ones I think of. I'll have someone do a test run at home when they're not about to go on stage, because I do not want them walking up all smiles and then pass out and hit their head. And then I get a lawsuit and on Yelp as a horrible dermatologist. So they're going to Netflix and chill, take it easy. I'm also going to do a resting blood pressure in my office. And if all goes well, they can let it rip, and that's where the sporadic, treatment with propanolol is useful. And then clonidine, you mentioned, I would put that maybe second or third line. I find it really good for hyperhidrosis associated with flushing. I also use it a lot in rosacea too, for the kind of persistent erythema or the flusher blushers. But I typically don't start with clonidine. If someone fails the rest, that's something I might grab.
And I think it's kind of interesting because, as more and more people move towards, social media being, in front of cameras all the time,
Yeah,
um, that could be a game changer for some of those people, giving
absolutely.
presentations and such. You also mentioned mirror dry in your lecture, and you mentioned it earlier. What experience do you have with that?
So personally, I've not. So I don't own. We don't have a device at GW. I do have a couple of voluntary faculty. He do, and actually, it's funny. I was just talking about a patient today about it. In terms of the options for axillary hyperhidrosis. I think it works pretty well. I think some of the shortcomings are that insurance doesn't pay for it, so it'll be
Right.
kind of costly. Though it can be a permanent solution. I find it's not perfect, but it does the trick. There is downtime associated with it. This is not a walk in the park where you roll in 5 minutes, you stroll out, and no one knows what happens. You get a lot of anesthesia locally. There's a lot of swelling and some discomfort for a couple days after. but it is a semi one and done type approach. And for the right patient, I think it's a great option. There was, unfortunately, I actually even brought this up with the patient, because what do most patients, you mentioned social media, what do most patients do nowadays? You suggest something they never heard of, they nod, they're like, oh, that's a great idea. And then they look at their phone, because their phone and Dr. Google know just as much or more than you, a trained
Right.
professional. And so what they may come across was an article about an influencer who died associated with mirror dry, but it wasn't mirror dry that caused the unfortunate death. It was actually a combination of medication and the anesthesia. But it's very easy to vilify a procedure or a technology, especially when you're dealing with such a tragedy. So I just want to rest everyone's put their fears aside, that mirror dry is absolutely safe when used by a trained professional.
Yeah. I personally have some experience with mirror dry. I've had a couple treatments done because we have the device in our practice, and I got to tell you, it changed my life. I used to sweat through my scrubs all the time. I used to have to buy new scrubs every so often because they were ruined from the antiperspirants that I would use. Dress shirts, same thing, and it's been a game changer for me. I can't say enough great things about it. I'm not sponsored by Mirror Dry or anything.
I think the company went out of business, actually, so it couldn't be.
Yeah, I'm just giving my own personal experience with it. But yeah, I really felt it did a good job. So
Yeah.
for those that still have the device, I think it'd be really really helpful.
I think that personal experience is so important. First of all, being someone who can understand that suffering in silence, gives you a unique perspective. I like you, I suffer with hyperhidrosis, and I'm happy to share that with patients, because, I take so much joy in managing these patients and getting them under control. And I understand more than most, just like how disabling it can be. And so the flip side is, when you get it better, it certainly can change one's perspective. Not to say that every healthcare practitioner needs to suffer through every condition to understand their patient, but I think using your own personal experience will make you more effective, but also it really allows you to teach others and really get them on board and share that passion for managing this condition.
Yes, sir. Yeah, I couldn't agree more. Thank you. Um, so we've talked a lot about treatments that are available to us now. Can you maybe share something? I know in your lecture you discussed a new medication that might be coming out pretty soon called sofpironium bromide, if I remember correctly.
Correct. Yeah, I mean, hopefully, and I say hopefully not because I'm conflicted, which I do. I do work with the company that is pushing Salon-Brickle, a biotech. I say hopefully because our armament is so tiny. I mean, think about this condition. This is a condition that affects millions upon millions of people in the United States, worldwide, and our options are quite limited. They've expanded a little bit recently, but we're talking about, single digits, one hand worth of options. So what's coming down the pike is another topical anticholinergic, that whose novelty is more how it's metabolized in the skin. So anticholinergics work great for hyperhidrosis, because what are they doing? They're blocking the receiver of acetylcholine. That forging, that partnership, is what's needed for the sweat glands to, of course, produce sweat. And in the case of hyperhidrosis, there's too much activity. There's a party that you did not want to be invited to. So here, and similarly to glycopronium tosylate, glycopyrrolate, oxybutynin, even onabotulinum toxin, which works peripherally to that, but still is affecting cholinergic signaling. This will block. However, it is rapidly metabolized in the skin to an inactive metabolite. Because while yes, these work well, we talked about it, they come with some baggage. Dry mouth, dry eyes. From a topical perspective, if you were to, rub your underarm and then touch your eye, mydriasis or dilated pupil. So there is some baggage when it comes to that. So if you're going to use a topical and try to bypass systemic administration, you would hope that you don't get systemic side effects or minimize those systemic side effects. And that's the idea here. This retrometabolic gets broken down to an inactive metabolite that when it gets absorbed systemically, it doesn't have the degree of expected adverse events you'd expect with an anticholinergic. This will be coming out on a roller too. It's not a wipe, it's, I believe, on a roller. So there may be some benefits in terms of ease of application. It's actually approved in a different concentration in Japan. So we can have some insight with respect to safety and efficacy from abroad. But I think it's coming down the pike relatively soon. I'm excited about it. There are some others coming out there. There, I believe, is a combo oral anticholinergic, and then it has pilocarpine associated. That's a combo drug to, in a similar vein, negate the anticholinergic side effects. So it'd be like, think of like glycopyrrolate with minimal, hopefully minimal side effect profile. So that's kind of the idea behind it. I don't know where it is in the scheme of things in terms of when we can expect that. No question, if all goes to plan, we'll see soft-protein bromide sooner. But I think to your point about what's coming next, we need what's coming next. I mean, there are so many patients out there that don't even know they're patients yet. And when you get new drugs, we saw this with Glycopronium Tosylate. We saw the patient education, direct-to-consumer marketing. It was an awakening of sorts that those who were suffering actually realized they were suffering, and this was a real condition. So the more industry invests and pays attention to this condition, guess what? Everyone else pays attention too.
Yeah, I think anything we can do to help our patients in terms of their condition, but just providing other options for them is so important.
Absolutely.
Like you said, so many of these patients suffer with this, don't even know that it's something that can be treated in most cases, like you mentioned. So all these novel medications, I think, are just going to improve the field of dermatology and help those patients more importantly.
Yeah, no question.
Couple other things I wanted to kind of just touch on. You at the very end of your lecture, you mentioned an article that you co-authored with Joe Gorlick that kind of did, from my understanding, was more like a deep dive into hyperhidrosis. And so for some of our colleagues who are rather new to the specialty, who maybe need a little extra help understanding the condition a little bit better, I thought it might be a great resource for them to look into. Where might they find that article?
Yeah, it was published, I believe, in the Journal of Drugs and Dermatology, which I'll say there's actually a lot of good articles, even scientific articles on hyperhidrosis. Actually, the largest satisfaction study surveying, I think it was over almost 1,200 sufferers with hyperhidrosis across the country with respect to their satisfaction of all the available options, which aren't many, was also published there. And I believe we've also, there should be some podcasts as well, jddonline.com, that's the website. I think there's some nice hyperhidrosis resources. The other, and I can't harp on them, thank them, appreciate them, honor them enough. The International Hyperhidrosis Society, sweathelp.org, super easy to remember. They have so many incredible resources, video libraries, articles, you name it. There was a series published in Dermatologic Therapy, which is also another journal that I believe they were intricately involved with, and a lot of their founders and board members were involved in writing some of those articles, ranging from everything we've talked about to we even talk about thinking about pediatric patients with hyperhidrosis. Wow. This is a condition that doesn't discriminate, and that goes for ages as well. And so you can imagine how at different ages, hyperhidrosis could have a different psychosocial impact. Think about, holding, your partner's first hand, holding hands with your first partner, or, playing sports, basketball, football. Think about everything, on, touch screen, a sweaty hand trying to swipe, or touch screen, it's not going to recognize it. So things that, maybe you and I didn't have to think about when we were growing up, there's some new challenges. And even challenges with therapies, because some of the side effects we talked about, children may not understand overheating or what it means to be anhydrotic, which could be an emergency. So I think that it's important to consider specific implications across the spectrum of ages and other demographics as well.
Yeah, you think hyperhidrosis is only something that affects adults, but like you mentioned in your lecture as well, if I recall, pediatric patients can be affected by just as much or
absolutely.
Yeah.
Actually, that's usually when it starts, just no one recognizes it. And when you get to the meat of it, when you have your adult patient who you happen to identify hyperhidrosis during a routine skin exam, you start diving in, you say, do you remember this being a problem, teenager, adolescent, like, oh, yeah, I do, but I just thought it was hormones. And,
Yeah.
I think this is a very similar vein with atopic dermatitis. I feel like these patients have become very good at making excuses and attributing their pathology to things they're doing or environment or anything because they don't understand it. And so I think they often will downplay how impactful it is until they realize it's a condition that we can treat. Then there's the floodgates open.
Um, One last thing I wanted to mention, kind of off topic. I read an article where you gave an interview. I think it was in the Dermatologist journal, and in it you mentioned that your father was one of your heroes and mentors, or one of your greatest heroes and mentors, amongst a number of different other dermatologists that have kind of helped you through your education and your career. But I was looking at some of the advice, some of the suggestions. I guess it was advice. They were like bullet points that he mentioned, and it really resonated with me. And I think it resonates with the times as well. But one of the ones I found to be most interesting was the very last one, which was "There's always time for basketball."
Yeah, no, it's true. I think he follows that today, even though he'd probably kill me if I said how old he is. Yeah, so where that really came from, he's still faculty at Albert Einstein College of Medicine. I've been performing research in his lab since I think high school and even through college, and then that's where I went to medical school and did my residency. So we've been doing research together forever, and a caveat of working in his lab and doing all this stuff was we always played basketball during lunchtime. Then no matter how busy you were, there was always time for basketball at the Einstein gym. And I think that just reminds us there always has to be time for something else. I think we get very caught up, and I am a huge offender of this. I mean, I'm terrible at saying no to things. I have terrible FOMO when it comes to opportunities for my career, regardless of where I am with it. But it's just like, it's fun. I love doing this stuff. There's more to life than that. And so in following, just to give you an update, following that advice, I guess my midlife crisis activity is I'm learning guitar now.
Oh,
So
nice.
I said, I'm like, you know what? I need to do something else besides work, besides managing hyperhidrosis and family and the typical things, things that you get caught up
Great.
in the real world. And so I'm now learning how to play guitar. I never said I was good, but it is. I gotta be honest. It's a big wellness thing, and that just the way that basketball was for the two of us, and still for him. So I think everyone has to find their basketball, and they have to recognize that there's always time for that activity because you need to be whole. I mean, I'm so glad you brought that up. That's such an important point that it's so easy to forget these days.
Yeah, I couldn't agree more. I think, especially with everything that everyone's gone through in these last 2 years, and the amounts of stress and anxiety that everyone's had to deal with, finding that outlet is of paramount importance. So,
Absolutely, well
so
said.
with that, Dr. Friedman, I just want to say thank you again. I genuinely appreciate you giving up your Monday evening. I understand you were lecturing earlier this evening, and so to come on and do this interview with me, I'm greatly honored. I really appreciate it.
My pleasure. It's been fun. Thank you.
Yes, sir. Thank you so much. With Dermcast TV, I'm Gilbert Saenz. Thanks a lot, guys.